Welcome back to EASD TV. We've got a very noisy environment around us. There's a real buzz, and if you hear lots of noise, it's just having a lot of people having a very good time. Now, talking about having a good time, we're talking adolescents with diabetes and what are the problems and complications that they may develop. And with me, two people who are in a session which is titled, Are Youth at Risk of Cardiovascular Disease? And as you both could say, yes.
Most definitely.
Definitely, and all go home. But anyway, let's introduce you. So, first of all, we have Amy Mottl from the University of North Carolina, who is a nephrologist, and Janet Snell-Bergeon from the University of Colorado Barbara Davis Center for Diabetes and Cardiovascular Disease, and you're a researcher.
Yes.
So, the obvious question is, yes, adolescents are at risk of complications, but you've been looking particularly at markers, haven't you, that might indicate who's most at risk.
Right.
Tell us a bit more about that.
Yes, so youth with diabetes, both type 1 and type 2, already show some differences in their cardiovascular health, even at very young ages. So that includes an increase particularly in arterial stiffness, so their blood vessels are being damaged, and they're ending up with blood pressure that's elevated. And we also can see some signs of damage in the heart. So we can use, for example, more advanced imaging techniques, so MRI of the heart, and we can detect some differences in how the heart is functioning, even at very young ages.
And that's in addition to all the kind of standard things that you might look at.
Right. So we typically look at A1C, we look at blood pressure, and we look at cholesterol. So looking beyond some of those just traditional targets of diabetes care, we find, for example, that even though hemoglobin A1C may be in good control at a later time, if they have poor control earlier on in life, there can be this metabolic memory where they end up at higher risk of cardiovascular disease. And if we start people on technology earlier, we've shown that people can maintain better glycemic control early in the course of their disease, and that should reduce complications.
So that early control really, really matters.
It does, yeah.
Now, you've been looking, Amy, at I think it's called the Search for Diabetes in Youth study. What have you found from that about complications in later life from those with youth diagnosed diabetes?
Right. So the SEARCH study is unique in that it looked at both youth onset type 1 as well as type 2 diabetes, which has really been pivotal for our understanding of the pathogenesis in type 2 diabetes, because most of us think that it doesn't occur in youth, but it turns out that there's actually a really rapidly growing rate of youth onset diabetes. Still, quite uncommon, but increasing, especially in people of minority race and ethnicity. And we're finding that, there's overwhelming early onset complications. It's very similar, interestingly, for retinopathy, because it's somewhat similar, about a 50% incidence at 12 and a half years diabetes duration. So these are people who are only in their mid to late 20s who are already having eye disease.
Really scary statistic.
It's very scary.
But then had that been realized before this study?
I think that there were some prior studies looking at type 1 diabetes, but no, I think this is the first we're really seeing that in type 2. And then the Today study, which started out as a clinical trial for treatment of youth onset diabetes, is also going to be discussed in this session, and they're finding very similar things. So the youth onset diabetes studies, both in SEARCH and Today, are very much emulating each other, which really tells us that this data is quite true. And I'll just add that kidney disease is...
I was going to ask you about kidney disease
so
as a
nephrologist. This is, very near and dear to my heart. And those with type 2 diabetes, the prevalence of sustained albuminuria, so that's leakage of protein into the urine, is about 26% in type 2 diabetes versus 10% in type 1 diabetes. And albuminuria is very solid in terms of a predictive factor for progression of kidney disease, meaning loss of kidney function and eventual need for dialysis and transplantation. So it's definitely, a moment where we need to sit up, pay attention, and find good treatments, or better yet, prevention for this.
Because adolescence is the time when you kick back against everything. Not just, your diabetes, the need for monitoring. And so the fact that we have found all these indicators of such poor prognosis for these kids with diabetes, how does that lead us into what we need to do next for them?
Well, one misconception, I think, is that all adolescents have terrible control and there's nothing that we can do about it. So we actually did a study of all of the patients who'd been seen at the Barbara Davis Center since its opening, and we looked at glycemic control. We actually found there were different trajectory groups where A1Cs actually were pretty steady throughout childhood through adolescence in most of the kids. So it's really a subset of kids who are really struggling. And a lot of it is the minority racial groups, as well as kids with earlier onset, and kids who gain more weight. So there's definitely, I think, a need to sort of target those individuals who are really struggling and figure out what we could do to help them.
So the first thing is lots of extra support for those who are most, and perhaps the ones that you've identified through those markers.
Right, yeah.
So give them lots of extra support.
If I can just add, so the Search in Today studies actually did a collaborative effort looking at access to health care with respect to insurance, especially with the expansion of Medicaid about 5 years ago, and really found that those who had health care coverage in early adulthood did better in terms of their glycemic control, and that the Medicaid expansion most certainly improved those who were insured, and hence those who had better glycemic control, which is really one of the mainstays for preventing early onset complications. And then the other thing that I'd like to add is actually food security. So there's a study ongoing in South Carolina where they're looking at food security and its impact on diabetes control in type 1 and type 2 diabetes, and that this really has huge implications in terms of diabetes control, because if you don't have access to food, it's hard to pay attention to your health as well.
And that's shocking in a rich country.
Mm-hmm. Most certainly.
Janet, you mentioned the importance. I mean, we've said, okay, support is and identification is the first stage, but you said the importance of getting kids to use CGM very early on.
Right. So even when there's insurance coverage, so for example, Medicaid covers the use of CGM now, what we've found is that not everyone is able to or chooses to take advantage of the available technology. So even at the Barbara Davis Center, we have a very heavy use of diabetes technology overall, which is unusual. There are a lot of kids who are being followed in places that don't have such great access. But even so, we see lower use of technology among minority youth. And so one thing we're doing right now is to try to understand what the reasons are for that. And some of it could be even if insurance covers the device, maybe they can't get to the appointments, or maybe the cost of the sensors or other supplies is too high. And there could also be issues with their perception of using the technology. So we're actually doing a study right now to try to find out more about why people are not choosing to use technology when it's available.
Can I ask you a question, which I mean, you may not be able to answer it, is when I've seen these kind of devices on the arm, they're always white.
Okay. Yeah.
Are there not ones that are more appropriate to different skin tones?
Yeah, that's interesting. I hadn't thought about that, but that is a good point in terms of not calling attention for darker skinned folks. Yeah, and I'll just add to what Janet was saying. There was a study that was done in Search where we looked at if youth with type 1 diabetes who were non-white receive similar treatments that those who are white are receiving, because there's huge disparities according to race ethnicity with respect to using CGMs and pumps. There was about a 30% improvement in A1C, as well as significant reductions in comparable microvascular complications. So that's a good point. Maybe we should bring that up to industry.
Yeah. And speaking of industry's role in maybe improving this, another barrier is language. So we have a large Latino population in our clinic, and a lot of the trainings aren't held in Spanish or in other languages, and even when there's help available that they can call a line with Spanish help available, I've heard that the wait times are quite long, and so there can be barriers just to using it.
The issue, I think, always is that the child or the adolescent may speak English perfectly well because they've been born in the US or born in the UK, but the parents have no command of English or very poor command of English, and it's often the parents who are supporting the child, and if that support isn't available because it's not available in a language that the parents understand, then that's extremely difficult.
Yeah, I think that's an important point, because we're really trying to expand access for people training to become healthcare providers to those who are non-white and non-English, or speak a second language, particularly Spanish. And so I think the reason is exactly what you said, so that we can provide further support for this growing population in the U.S.
Okay, so I'm going to ask each of you to give some advice to an ordinary diabetologist, knowing all that you know. What would you say to an ordinary, not of course that any of you are ordinary, what would you say to an ordinary diabetologist, regular diabetologist, if he has an adolescent come to him? What would you, or her?
Sure. I think frequent contact makes a big difference in terms of outreach, whether it's from the diabetologists themselves or their nursing staff, their medical assistants. So I think that's one of those things. But also speaking directly to the patient, the adolescent, and not the parents, I think that can go very far as well in terms of gaining, that interpersonal connection, that trust, so that the adolescent really buys into what they need to do to protect their long-term health.
And I'm guessing your advice would be go beyond the usual markers.
Yeah, I think going beyond the usual markers, I think a lot of diabetologists maybe also haven't become as familiar with technology. So, just depending on whether they're a pediatric endocrinologist, they may be more familiar, but there are a lot of people taking care of people with diabetes who maybe are in primary care. And so I think it's really important for them to look for resources to learn more about the technology that they could prescribe for their patients, because a lot of people aren't prescribed technology because their physician doesn't feel comfortable with prescribing it or supporting them in using it. And also, going to Amy's point, really problem solving with an adolescent can be helpful in terms of engaging them with, okay, what are two things that we could change between this appointment and your next appointment, rather than kind of trying to tell them what to do, seeing, what do you think you could do to change
That's never worked, has it?
And, telling them what to do doesn't work, I know.
And overwhelmingly, I'm hearing from you, get them on CGM as soon as possible.
Yeah, I think that has been shown to be beneficial.
Yes.
Fantastic. Thank you both so much. And actually, I've got something for the manufacturers. Please, can you manufacture your devices in different skin tones? It would make a big impact for adolescents. Thank you so much. You've been listening and watching EASD TV. We'll be back with you again soon. Bye for now.